All right, let's dive right into this explainer. Today, we're breaking down a really brilliant, highly effective clinical cheat sheet for mastering respiratory failure types. You know, when you've got a patient struggling to breathe, the sheer volume of potential underlying issues can honestly be overwhelming. But today, we're going to take the complex physiology of the human lung and just boil it down to a few simple, unforgettable rules that you can literally use on the floor right away. Picture this. You're in a high-pressure clinical environment. You know your patient is in respiratory failure, but to treat them effectively and quickly, you absolutely have to know what kind of failure is happening inside their body. Treating the wrong type can be disastrous. Well, the source material we're looking at today tackles this common clinical anxiety head-on. It asks the most fundamental question. Respiratory failure has two distinct types, so how do we actually differentiate them? You might think you need to memorize this massive textbook of symptoms, but it turns out there's a simple, almost mathematical trick to solving this whole puzzle. And here's that foundational rule from our clinical guide. This is the key to the whole system. On the left side, we have 1 equals 1, and on the right, 2 equals 2. That is the golden rule. We're going to see how these incredibly simple numbers map perfectly to the body's chemical disturbances. Because by just remembering 1 equals 1 and 2 equals 2, you can instantly categorize what is physically going wrong in a patient's lungs. So let's kick things off with type 1, the diffusion problem. Okay, let's apply our rule. The absolutely crucial point here is that 1 equals 1 concept. In type 1 respiratory failure, there is exactly one chemical disturbance in the blood. Just one. The oxygen levels drop, so they're abnormally low, but the carbon dioxide, the CO2, remains perfectly normal. So one type of failure equals one single disturbance. The body is fundamentally failing to bring that life-sustaining oxygen in, but it's still managing to clear out the waste gas. And you might be wondering, why is that? Well, it's because carbon dioxide actually diffuses much easier across cell membranes than oxygen does. So even when a lung is damaged, it can usually still blow off that CO2, leaving us with just that single disturbance of low oxygen. The physical mechanism here is fundamentally a story of a roadblock. The source material notes that type 1 is defined by a decreased diffusion capacity. So what does that actually mean? Well, oxygen is trying to cross from the lungs into the bloodstream, but it hits a physical barrier. Specifically, fluid or blood. It simply cannot diffuse across that barrier. The oxygen hits this invading fluid and just stops dead in its tracks. Now let's see how this builds into real-world clinical diagnoses. We've got pneumonia, pulmonary embolism, ARDS, heart failure, pulmonary edema, septic shock, and early asthma. Let's take a second to look at what these actually have in common, based on what we just learned. Heart failure and pulmonary edema literally back fluid up into the lungs because the heart isn't pumping effectively. Pneumonia fills those microscopic air sacs, the alveoli, with inflammatory pus and fluid. Acute respiratory distress syndrome, or ARDS, causes this massive systemic inflammation that leads to fluid leaking directly into the lung tissue. And a pulmonary embolism throws a clot that physically messes with the blood flow itself. Every single one of these conditions triggers that exact physical fluid or blood roadblock, ruining the lung's diffusion capacity and causing that single disturbance, low oxygen. Now let's shift gears and look at what happens when the mechanical failure completely changes in type 2, the retention problem. Remember our mathematical rule. For type 2, the rule is 2 equals 2. This means we are no longer dealing with just a single problem. In type 2 respiratory failure, there are two distinct chemical disturbances. We have the low oxygen, just like before, but now we've gained a secondary, highly dangerous disturbance, increased carbon dioxide. The lungs are failing on both fronts. They can't get the good gas in, and they can't get the bad gas out. And that trapped CO2 is incredibly dangerous. As it builds up, it turns acidic in the blood, which can rapidly lead to severe lethargy and eventually a coma if it's left untreated. So why does this happen? The source explicitly points to CO2 retention in the lung, but the mechanics are totally different from type 1. We aren't looking at fluid blocking diffusion anymore. Instead, this is all about exhaustion and restriction. The CO2 is trapped because of either a failure to move the respiratory muscles or a severe narrowing of the airways. Think of it this way. The body's mechanical pump is either too weak to push the air out, or the pipes themselves are just too tight to let the air escape. Look at how perfectly these causes map to that mechanical failure. In the muscle failure category, we have neuromuscular disease, general muscle weakness, or drugs like opioids and diazepam. These drugs depress the central nervous system, literally blunting the brain's signal telling the muscles to breathe. The pump just stops working. Then look at the narrowing and restriction category, obesity, apnea, and COPD.
In COPD, chronic inflammation physically restricts the airways and destroys the elasticity of the lungs, meaning the air goes in but just cannot get pushed back out through those tight pipes. Whether the muscles are too weak to move or the airways are physically restricted, the result is exactly the same: dangerous CO2 retention alongside low oxygen.
Let's zero in on one incredibly common condition that actually bridges both of these categories: the asthma progression from type 1 to type 2. So, if you were paying close attention to those cause lists, you might have noticed a kind of hidden anomaly regarding asthma. Early asthma is classified as type 1, just low oxygen. But severe asthma morphs into type 2. This means asthma actively progresses. It starts as a diffusion issue, usually from some early inflammation and mucus plugging, dropping the oxygen. But as it becomes severe, the airways narrow so drastically and the respiratory muscles become so deeply exhausted from fighting for air that the patient loses the ability to blow off carbon dioxide. They literally graduate from a 1=1 crisis into a full-blown 2=2 retention crisis. This brings us to the final and really the most crucial part of our explainer: mastering the diagnosis and understanding the clinical stakes. We've covered the mechanics, the fluid, the muscles, and the narrowing, but it all comes back to the patient in front of you. When a patient is struggling for air, will you know if you're fighting a diffusion problem or a retention problem? By holding on to this incredibly simple framework, knowing that a single disturbance of low oxygen means 1=1, a diffusion block from fluid or blood, and knowing that 2 disturbances of low oxygen and high CO2 means 2=2, a mechanical retention problem, you can instantly decode what the body is doing. You aren't just guessing anymore, you're reading the chemical signals perfectly. Keep that 1=1 and 2=2 trick locked in your memory. But it leaves us with one final question for your practice. Once you've identified whether it's a diffusion or a retention problem, do you know the exact first-line intervention to save that specific patient's airway?